Ms Carey.
Thank you, my lady. Mr Hancock, can we turn to PPE, please? Do you accept that at times healthcare workers treated COVID-19 patients with inadequate PPE, thereby putting themselves at potential risk?
Yes.
Did you understand that FFP3 masks were more protective than FRSM blue masks?
Yes.
Can you help, please, with who led you to that understanding that the FFP3 was more protective?
Well, it's obvious. So I'm not sure I was ever told it technically, but if I were taken through the performance of different parts of elements of PPE, it would have been by Ruth May.
All right. Did Public Health England ever say to you, in fact, there's no clinical evidence on the ground that FFP3 are more protective than the blue masks?
Not that I can recall, no.
All right. Would it surprise you to learn that we've heard evidence to that effect?
I saw that, and in these things, I take the evidence as given by the experts.
All right. You are aware, presumably, though, that there were lots of bodies acting on behalf of healthcare workers arguing for increased usage of FFP3 throughout the pandemic?
Yes.
All right. And I think, in fact, you received a number of letters from BMA, RCN, TUC, CATA, as it's now called, or CAPA, as it then was, urging you to allow FFP3 usage more widely than the IPC guidance enabled.
Yes, and not only receive letters, that again gives the impression that this was somehow a dry exercise, which obviously you get from the paperwork by its nature. But I spoke to I spoke to all these people as well in the Royal Colleges, and more than anybody, Donna Kinnair, who was the head of the RCN at the time.
Did you understand that that desire for increased usage of FFP3 was linked to an argument that COVID transmitted via aerosol transmission?
Yes.
And can I ask you about that, please? To what extent, if any, were you involved in arguments or aware of arguments about the extent to which COVID transmitted via aerosols?
Of course, I was acutely aware of these things, and that debate.
You said this morning that you would advocate for a precautionary principle being adopted in relation to asymptomatic transmission.
Yeah.
And can I just ask you, please, what do you understand the precautionary principle to mean?
Well, you have to take into account the reasonable worst-case scenario and act on that basis where you can. So the central balancing that had to be done with respect to PPE was supply set against precautionary healthcare considerations. So, and that's what those drawing up the IPC recommendations did. They had to balance what was available and realistically available to buy with what was needed to, all with the goal of saving the most lives. I left that balance to them to make, and I regarded it as an essentially clinical decision, taking into account available stock, the IPC decision. That isn't something that I would have interfered with, or indeed did interfere with.
Pausing there, you were not responsible, as we know, for drafting the IPC guidance, or indeed approving it, as I understand it. Is that correct?
That's correct, yeah.
But are you saying to us that you were of the view that IPC guidance was drawn up on the basis of what was available, not what was actually necessary to be recommended to healthcare workers?
In a pandemic, availability of stock has to be taken into account, because if you promise, imagine if the IPC guidance had retained the initial hazmat style,
The HSID designation.
the definition, that would simply not have been possible. And so there is an element of the art of what is possible. In the same way that whilst I wasn't individually involved in signing contracts for PPE, I was deeply involved in trying to push the system to buy more. But on the IPC guidance itself, of course you have to consider what is feasible, because this isn't some academic exercise, it's about saving lives. But in terms of when that IPC guidance was then drawn up, I didn't sign off on it, and I accepted the guidance as essentially a piece of clinical guidance with which I wouldn't quibble. If I had a question around it, I'd go to Ruth May and I'd talk to Donna about these things all the way through.
Are you aware of the basis upon which COVID was downgraded or declassified as an HSID and why that decision was taken?
Yes, I think the decision was obvious in a sense because spread had got wider than this being a very rare and single occurrence. But again, that wasn't my decision. It was a clinical decision, I think, in that case by the CMO.
It may be ACDP and NervTag, but put aside who it was that made that decision. It was in fact declassified because it was less fatal than other coronaviruses that we've heard of. You're not suggesting, are you, that it was downgraded because we wouldn't have had enough PPE to maintain the HSID classification?
My example was that if you tried to maintain it, it would not have been feasible.
Right. We have heard evidence from the IPC guidance, those drafting the IPC guidance, that issues of supply did not in fact affect the guidance that they issued. Are you suggesting to the contrary, Mr. Hancock?
No, I'm suggesting that that I wasn't involved in the drafting of it, but my point about supply is you do have to live in the real world whilst you're fighting a pandemic.
No.
Of course, people who were drafting the guidance would also have been aware of it. The balancing point here is that the practical reality is that there is a certain amount of PPE and you have to use it as effectively as you can whilst buying as much of it as possible. That is the real world reality here.
You said this morning, in relation to the precautionary principle, you adopted it, absolutely, which we did on things like guidelines around the use of PPE within hospitals.
Yes.
In what way do you say the guidelines around PPE in hospitals adopted that precautionary principle?
Well, for instance, the use of masks, which was required as part of the IPC, which was not recommended to the general public. The failure to recommend it to the general public until later was directly a consequence of asymptomatic transmission being ruled out in the official advice, yet it was adopted within hospitals, demonstrating that there was an element of the precautionary principle there.
There will be those, many in this room no doubt, that say if you were truly adopting a precautionary principle, FFP3 would have been used, not the blue masks. Do you have any views or comments to make on that suggestion?
I can absolutely see that argument, and had FFP3 masks been recommended, I would have accepted that. But as I say, that was a clinical decision for the team who put together the IPC recommendation, not for me.
Can we take a stage back to the stockpile, please?
Yeah.
And you say in your witness statement that as at the 30th of January of 2020, you received Public Health England's audit of the PPE stockpile, and there was no clear record of what was in the stockpile, and some kit was past its sell-by date.
Yes.
The inquiry's also heard that as at the 18th of February, the stockpile did not contain a single gown. Were you aware that there was no gowns in the PPE stockpile?
Well, I was once I found that out, but I wasn't in advance, no.
No. All right, so what did you find out about it around the end of January, beginning of February, something?
Yes, I asked for that audit at around that time, yeah.
Were you made aware that NervTag in June 2019 recommended getting surgical gowns in for the event of even a flu outbreak?
I don't recall being aware of it, but obviously I've seen it in the evidence in the inquiry.
Yeah. Had you been made aware that there was a need for gowns, would you have been able to apply any pressure to speed up the procurement process?
Rather like our discussions about the lines of accountability with NHS England, similarly with PHE, I certainly could have raised that with the PHE leadership, but it would have been their responsibility to do it. I say this because the clarity around the roles within the health system was really clear. The fact that would have been effectively an independent decision by them doesn't mean that we had any lack of clarity over whose decision it was. In the same way that I know what was Simon Stevens' decisions on the NHSE side, what was my decisions, and if there was an ambiguity, we would put it on a quad agenda and discuss it.
But who would provide the funding for getting more PPE?
That would come from PHE's budget, but obviously one of my roles with respect to PHE was to fight for their budget.
So Christopher Wormold told us it was entirely normal government procurement that meant that even though it was recommended in buy gowns in June, by February 2028, months on, we still haven't got a single gown in the stockpile.
Yes.
Do you accept, though, that entering the coronavirus pandemic as we did without a single gown severely hampered the ability to provide safe and appropriate PPE for healthcare workers?
The stockpile that we had was not as good as it needs to be in the future, absolutely. But I saw Sir Chris's evidence, and he was absolutely right, if I may say so. There have been some criticisms of the department, indeed me personally, because of the accelerated procurement that we put in place. This is an example of normal procurement processes, so you can see why we needed to accelerate them. This is how slowly government buys stuff. It's just really, really slow. And it's gone back to being incredibly slow since the pandemic. That's just life in government. I don't like it, by the way. I think we should buy stuff quicker, but that's,
yeah, it sounds rather fatalistic, doesn't it?
Yeah, but he was completely accurate in describing it as normal government procurement. I mean, sometimes this stuff takes even longer.
You say in your statement that the one of the other problems with stockpile is it was not spread across the country.
Yeah.
And that the warehouse that held the stockpile had only one main door,
Yeah.
which slowed the distribution of PPE.
Yeah.
So is this a fair summary? There was no clear record of what was in it.
Yeah.
There was a total absence of some PPE, namely gowns. And to boot, there are clear problems getting your hands on it because the warehouse has only got one door.
And some of it was out of date once we got our hands on it, yes. Why there wasn't a precise list of what it was in an easily pickable way with a computer system that could tell you where different bits of kit were, preferably with photographs attached of an example of it, for instance, as you would have in a modern, efficient storage system, I do not know.
All right. By the time you left office, was there such a list that you were aware of?
Yes.
All right.
But I still wouldn't say that by the time I left office it was comprehensive, but we were much further along the route, and we had pickable PPE stockpiles in lots of locations, and indeed there was a problem that we ended up overbuying PPE because the PPE demand fell again, and the department after my time ended up with too much PPE.
Jean Freeman told us that she thought that having a rolling stockpile, which would entail distributing PPE on a rolling basis to prevent it expiring, would help in the future. Would you agree or disagree with that?
I think that's a typically astute observation from Jean Freeman.
Can you help, or do you know why we didn't have that, since it seems to be a relatively simple solution to a problem that we encountered?
I have absolutely no idea.
All right. Mr. Hancock, from your perspective, did England ever run out of PPE for the NHS?
As a whole, no, but individual locations did.
All right, so you accept that we came close?
We came extremely close. We came within, small numbers of items on a regular basis during April and May 2020.
Yeah, all right.
By the second wave, we were in better shape.
Yeah, all right. I'd like to just to look at perhaps some of those examples. I think you are aware in April 2020 that there were reports that a hospital in North London, Northwick Park, had no critical care beds left. And in fact, there were exhausted nurses wearing bin bags to protect themselves. And I'd just like to call up that article, please, INQ 474608. Excuse me. It's Thursday, the 9th of April. It's an article in The Independent. And there are 3 nurses there wearing their bin bags. And perhaps if we could just scroll through the article, they say they've now been diagnosed with COVID after they were forced to wear bin bags. They were pictured last month amid a shortage of masks, gowns and gloves. And if we scroll down again, I think there may be another photo, or it may not come up on our screen. There we are, it does. Nurses added, there are too many COVID patients coming in to cope with. We put on our brave smiles, but inside we're terrified. I'm asked to ask you, as the person with ultimate responsibility for health and social care, how did the UK reach the point that healthcare workers are having to wear bin bags?
Well, in this instance, I saw these reports and asked whether that hospital had enough PPE, and I was told that it had had regular PPE deliveries in the preceding days, and that the hospital itself reported back that it had adequate PPE supplies. So all I can do is tell you what I was told at the time, and I was immediately on it to try to solve these sorts of problems. But of course, there were individual shortages because this was a massive logistical operation under extreme pressure.
Can I ask you, when you say I was immediately on it to try and solve these problems, what did you actually do? Help us with what you did.
There are some there's some exhibits that explain what happened. I saw these reports.
Yeah.
I also heard other reports. I asked the department to get in contact directly with the hospital, and the hospital reported that it had adequate PPE supplies. And this is an example of the fact that within the NHS, within a logistical operation of suddenly having to get PPE out to effectively 1.4 million people and social care, there are inevitably problems and challenges. Obviously, the logistical operation is a matter for the NHS. What I was trying to do, and what we effectively did do, was ensure that there was always overall PPE supply, but it got extremely close, sometimes within hours.
Yeah.
And for the people operating that PPE supply chain on the ground, it was incredibly difficult because they'd go from, in normal times, having PPE supplies, coming in at a scheduled rate in an organised way, to suddenly waiting for the next batch of PPE to arrive before they could distribute it around the hospital. So I'm not criticising.
If you could focus on Ms. Carey's question. Essentially, you discover through your officials making inquiries that the hospitals say they've got supplies.
Yeah.
The nurses say they haven't. Did you just accept that conflict, or did you say, what's going on? Why aren't the supplies, if they're there, being distributed around the hospital?
Well,
Ms. Carey's question was, what did you do?
So the answer to the precise question, what I did, was I found out whether that hospital had supplies.
Yep.
My responsibility was not to distribute it within the hospital. I raised and discussed PPE distribution repeatedly with NHS England management, and they too were extremely keen to ensure that the PPE we had got distributed properly within the NHS system. At the same time, we tried to improve the delivery systems to different hospitals.
But that's a different problem. That is getting the supplies to the hospital.
Yes.
Here, there seems to be a problem with getting the supplies distributed around the hospital.
Absolutely.
Did you do anything about that?
The answer is that I spoke to the NHS about that because it's not something that I, as Secretary of State, personally could have done in every hospital. You have to run the system. You have to run I ran the department and then spoke to the NHS. So effectively, it's the management of that hospital who's responsible for getting the PPE supplies out of the from where it's received in the hospital out to the parts that
In your statement, you say that data about PPE was first incorporated into the COVID dashboard on the 21st of March 2020. And you were aware, certainly by mid-April, that there was a potential for, quote-unquote, a stock out. Does that mean no more stock? Is that
Yes.
Right. In relation to gowns.
Yeah.
And I'd like to ask you, please, about an email chain just showing how close we came to that. Can we have on screen INQ 478872? And I don't know if it's possible to expand the table at the bottom. Let's just see if we can. Thank you very much. But number of weeks after 10th of April until stock out, and if we just look at gowns, no more weeks.
Yeah, tell me about it.
1.9 weeks of aprons, 2 weeks of cleaning equipment, nearly 3 weeks, and so on, 3 weeks of gloves.
Gowns, I think at one point we got to within 6 or 7 hours of running out.
Yeah. Go back, please, to page 1. There's certainly reference to days. I'm going to ask you about hours in a minute, but thanks to Emily for the update. We've enough gowns to get through tomorrow and enough coming in tomorrow for the next day. No trust has run out, but there's been lots of mutual aid, especially in London, i.e. trusts or hospitals
helping each other out.
Is that the Foreign and Commonwealth Office are looking into mutual aid, and they've cleared a deal with Egypt. The dashboard shows we're out of stock. We've got 60,000. We need to send out 60,000. And you're relying on a delivery from Amazon, no less, for another 60,000. Were we running out of gowns to the hour?
Yes. We were working incredibly hard to make sure that we didn't have a stock out, and we nearly did.
And one of the responses to that was, I think you effectively were aware that PHE produced acute shortages guidance on the 17th of April, which allowed for sessional use or reuse of some PPE, including gowns and masks in specified circumstances. Do you remember being asked to approve that guidance?
I'm not sure whether I approved it or whether it went through the IPC approvals process.
It went, I can tell you, we've seen an email chain, it goes through you and you approved the guidance.
Okay.
Do you accept that the failure to have gowns in the PPE stockpile resulted in part for the need for that acute shortage?
Yes, of course, if we'd had more gowns at the start. So that is literally true in the way you ask it. There's also a broader point, because we have to, I come back to this point that what matters is, what I was responsible for was making sure the system as a whole operated as well as it possibly could to save as many lives as possible. And that was my job. Chris Wormald makes the point that we had about 500 million items in the initial stockpile. We used 15 billion during the pandemic as a whole. It is not feasible to have 15 billion in a stockpile. But it is, of course, literally true in the way that you asked the question, that if we'd had a million gowns at the start, we would have been a million further away from running out, which would have been several days, and therefore avoided being this close. But we were this close, and we worked incredibly hard to ensure that there was as much as there was.
Were you aware that that acute shortages guidance caused real upset, in particular to the Royal College of Nursing, who didn't support the guidance?
Yes.
And in relation to the Royal College of Nursing, they were so concerned by April 2020. Were you aware that they introduced some guidance to the nurses on the circumstances in which nurses could refuse to treat?
Yes.
What did you do when you learnt that the RCN had to go so far as to bring in a refusal to treat guidance?
Well, I spoke to Donna Kinnair at this point, and it was understandable that some people would feel uncomfortable with this guidance, because I didn't want to see that guidance in place either. But the challenge was, how do you save as many lives as possible, right? That was the objective here. And the advice I got, which I signed off, was that in certain circumstances, reuse of PPE is better than no PPE. And I accepted that point.
I follow the reuse or sessional use of PPE being better than none, but what did it strike you as saying about the way the system had prepared itself and was coping if the Royal College of Nursing have to produce guidance which says to the nurses at some point in certain circumstances you can actually refuse to treat a patient?
Well, the Royal College of Nursing represented one view, and my clinical advisors on this, represented by and led by the Chief Nursing Officer, Ruth May, took into account all of these considerations and made the best decision that they could based on the saving as many lives as possible. It's perfectly reasonable for a trade union to take a different view, but that doesn't necessarily mean that they're right. But we had a high-quality dialogue throughout this. In fact, Donna Kinnair, as head of the RCN, and I were involved in working together to try to buy more PPE as well. So they were absolutely leaning into trying to solve the problem, and it's totally reasonable for a trade union and the chief nurse responsible for the system as a whole to have different views on how to respond to a very difficult situation.
Did you or anyone else in the department ever discuss the possibility of a widespread refusal to treat by UK healthcare workers?
No, I didn't think we didn't expect a refusal to treat to become widespread. And also, I was in conversation with people on the front line as well, and my sense was that everybody really was trying their very best in very difficult circumstances. And that was the attitude of the whole system. So whilst there may have been some who took the view of the RCN, actually the vast majority of people were just doing their best in awful circumstances. And frankly, that was the attitude of within the health system, setting aside the problems that we had in central government, within the health system, that was basically the attitude that everybody took all the way through. And I think that's reflected in all of the paperwork that you've seen.
You make the point a number of times in your statement that whilst you acknowledge there were individual shortages, at no stage there was a national shortage.
Yeah.
And can I ask you, Mr. Hancock, bluntly, is that really the point? Is it not cold comfort for those that were down to the last hour's worth of masks or gowns or gloves?
Well, it's better to be down to the last hour's worth than to run out. And in some places, they did run out, and that was awful. And my job was to ensure that happened as little as possible, and nationally we never ran out of it. In a way, it comes back to the difference between semantics and substance, right? The reason this inquiry is so valuable to the nation, so important, is to get to the substance of it. So, I don't really get hung up on the semantics of it. What I care about is that in future we need to have better PPE stockpiles. We need to learn the lessons of what went wrong, and this inquiry, frankly, is at its best when it's focusing on that, and that's what really matters.
I didn't ask you about semantics, Mr. Hancock. I was asking you, or making the point, that although nationally there was available PPE, that's not particularly helpful, is it, to the healthcare workers that had to struggle on and reuse PPE? It's not semantics, is it? Are you trying to present a rosier picture of the PPE position than was in fact the case, given the evidence that we've shown you?
No, I'm not. I'm being absolutely clear about what happened and what lessons we need to draw for the future. What happened was there were individual stockouts in individual places. There was not a national stockout. In a way, one of the lessons we can draw is that even if there isn't a national stockout, there still are problems in local areas, and therefore not running out isn't good enough. We need to make sure that PPE is widely available, easy to get hold of. So what the point I'm making, and the reason I'm making it emphatically, is that what matters is the substance of being able to protect lives, and that's what we cared about in the health department, and spent every hour that we possibly could solving that problem. Now, how does that feel to the nurse on the ground? Well, what they care about is there PPE for me today?
Yeah.
Yeah, and that's what I cared about, and the role I could play, and the responsibility we had as a department, as opposed to the responsibility of an individual hospital chief executive to do the distribution within a hospital. Our responsibility was to make sure that there was as much PPE available as possible in the almost impossible global circumstances of the sharp rise in demand.
From your perspective, was there any link in your mind between shortages of PPE and the rising rates of people who are acquiring COVID in hospitals?
That is a very important question. I don't know the answer to that. I have seen evidence that there was no recorded deaths as a consequence, but I've also seen evidence to the contrary, and that is that's a research question.
Now, I follow that. I take the point that statistics may or may not ever be able to determine.
Yeah, it's a bit like asymptomatic
I know,
transmission.
but that's why I wanted to know from your perspective whether you were worried that there was in fact that link.
Oh, I worried about it. Whether it actually happened or not, I don't know. But of course I worried about it.
Right. Can we have a look, please, at the rates of nosocomial infection? And can I ask, please, that's put, excuse me, put on screen 348633_11. This is a PHE document looking at deaths, well, the rate of hospital-acquired infection and indeed the deaths that may have flowed from that.
Yeah.
And to help you, they've covered the whole time and then they've covered the waves, just looking at the whole time period. HOHA, hospital onset, hospital acquired.
Yeah.
All right, and I'm not going to ask about hospital onset suspected, but from this purposes, across the whole period, there were nearly 30,000 cases of hospital onset, hospital acquired COVID, of which 9,854 people died.
Yeah.
33%, and the average age of people died was 75. And if you just look at the waves, wave 1, over 8,500 cases and 3,000 deaths. And if we just look at wave 2, a far higher proportion of cases, 21,000 it jumps up to, 6,000 deaths, although the proportion overall is about a third, if I can put it like that. Again, the mean age of the people dying in both waves is 75. On any view, they are shocking statistics, are they not?
Absolutely.
Right, now, you said earlier this morning that hospitals are dangerous places to be in pandemics.
Yeah.
And I suspect this is what you had in mind when you made that observation.
Yeah.
But it might have struck many in this room as a rather curious thing to say that the very place people go to get better, in fact, is a place where they get infection and may indeed, in fact, go on to die.
Yes.
Right. Help us, please. At what stage did you become aware of the risks of hospital-acquired COVID?
The moment I heard that there was a new infectious disease, so January 2020.
January 20, right.
Yeah, it's not like I became aware of it. It's obvious. Right. I was involved in efforts to reduce nosocomial infection before COVID from other diseases.
Yeah.
You know, nosocomial infection is a very serious problem in health systems everywhere, but the NHS has a particular problem with it. If you think back to the MRSA scandals, etc.
Yeah, I'm not suggesting it solely affects COVID. We're well aware it's...
No, but also the question, you asked the question, when did you become aware? My answer is, it wasn't like, somebody wrote me a note and said this is going to be a problem. It was just like, well, obviously we're going to have a problem with this.
Okay, so when you became aware of the new disease in January 2020 and ergo the risk at the very least of nosocomial infection, what did you actually do to try as best you could mitigate that risk?
Well, we were aware of it from the start, and tackling nosocomial infection is clearly a responsibility of the NHS, making sure, for instance, that the hospital PPE guidance, as opposed to the guidance to the general public, was precautionary, was an important part of it. And again, these are discussions I would have had with Simon Stevens as part of the Quad process, because preventing nosocomial infection is a key responsibility of the NHS.
Yeah, but what did you actually say to him to say, I want to get on top of this as best I can?
I'm not sure I would have phrased it like that. I would have said, we need to tackle this. He put in place a lead for tackling nosocomial infection. We had the IPC guidance itself was a major step in tackling nosocomial infection. And then when we got to testing, we introduced testing in hospitals as soon as we had the tests available to do so. Just to give a flavour, one example of the problems that we faced and the cultural problem of tackling nosocomial infection in the NHS is this. When we got to enough tests and we talked about increasing testing in the NHS, some hospitals said they did not want to test their staff because they might find too many staff with COVID. Now, my response to that is, if you have staff with COVID, we need to know that so that they can go home and stop infecting patients. But some hospitals refuse to bring in testing for their staff. And the NHS at the centre, NHS England, pushed incredibly hard to get testing to everybody. But the fact that somebody might say, we're not going to test because, what's that going to do to our shift patterns if people have to go home, is an example of, in my view, a cultural problem within the NHS that it simply does not do enough to tackle nosocomial infection. And I'd been worried about that from before the pandemic, and it's something that I raised from January 2020 onwards. But again, the responsibility for dealing with that lies with the NHS, because you can't, tackling nosocomial infection involves decisions that filter all the way down to what happens on every individual ward.
When you got reports that there were some hospitals saying they didn't want to do the testing lest it reduced their ability to staff, what did you do about it?
I was deeply frustrated about it. I tried to bring in. I had meetings with obviously Simon Stevens, but also Pauline Phillip and Ruth May. We in the end we brought in protocols to require it, but the take-up of testing was piecemeal and slow within hospitals, slower than it should have been.
Macquarie has heard evidence. In fact, people wanted the test because it might enhance the numbers of staff, because in fact they weren't COVID positive, they could come back to work. Did you hear evidence of that as well?
Yeah, absolutely. That was a big part of the drive,
You've mentioned there the importance of IPC measures in trying to tackle nosocomial infection. And I think you're aware, Mr. Hancock, that the inquiry had a number of spotlight hospitals that were asked about these matters. Watford, for example, said they couldn't maintain 2 metres between bed spaces and had to use curtains because of the layout of the state. They didn't have ward ventilation that was appropriate, so had to use mobile HEPA filters. They didn't have separate entrances. They didn't have waiting areas that could be segregated. They had shared bathroom facilities that couldn't be segregated. They didn't have enough single rooms.
Absolutely.
Clearly, the NHS estate covers old, new, and everything in between. But, for the older estates, how practical was it from your perspective to ask them to rely on IPC when they had absolutely no possibility of being able to implement half the IPC measures?
Oh, well, it's absolutely critical that these things are improved. You mentioned Watford Hospital, and as an example of the things that I did to try to solve this and other problems is I commissioned a new hospital for Watford. And so Watford Hospital is now being rebuilt as the new part of the New Hospitals Programme. So that's one very literally concrete example of efforts to make this better in the future.
You say that in relation to nosocomial infections, you've been asked about any concerns that you're made aware regarding adequacy of ventilation in hospitals. And you say, I was highly concerned about IPC in hospitals, including appropriate ventilation, though this was, of course, a matter for the NHS. What did you do, if anything, to ask NHS leaders about improving ventilation in those settings, particularly in the older estate?
Well, that will have formed part of my discussions that I mentioned with the NHS leadership.
But what did you actually do apart from discussing with it?
Well, the NHS was statutorily independent. And so in asking or pushing them to do things, that was my responsibility. They were responsible. That's why, so these questions are incredibly important and absolutely proper to ask the Chief Executive of the NHS.
Right, you've said that a number of times.
But that's because it's the answer.
There may be many, though, that think that you, as the head of the Department of Health and Social Care, these are appropriate questions for you to answer as well. They're not let me just finish, please. No one's suggesting, Mr. Hancock, that you can walk down to Watford General and hand them over a bag of gowns or a roll of aprons. All right, I understand that. But we do want to ask you about the practical steps you took as Minister to ensure that these problems weren't happening.
Yes.
That's why I'm asking you.
Yes,
right?
I understand that. But I'm giving you answers because they are the truth. So I did all of those things, all the way from I actually did go down to an ambulance station in Deptford and personally helped move some of the PPE kit. But obviously, me doing that is not going to solve this problem. All the way through to rebuilding Watford General Hospital. But the day-to-day operational independence of the NHS means that whilst I could do everything I could within my remit, the responsibility for nosocomial infection minimisation in the NHS is a matter for the NHS, and I'm sorry to keep coming to it, but that's because the accountabilities were clear. You know, we've heard in other parts of the inquiry problems of muddied accountability. I'm being clear about the accountability. Now, as it happens, also, I'm not fatalistic about this either, because I thought that statutory independence was wrong, because all I could do was push and ask, and therefore I drafted the bill which became the Health and Social Care Act 2023, which revoked that statutory independence. In a sense, that's another answer to your question, and certainly will help, I think, in the future. But running systems of 1.4 million people through a filter of statutory independence is a challenge, but I say none of this to criticise Simon Stevens, who did an absolutely brilliant job. I simply say it as an accurate answer to your question that many of them are correct, would appropriately be directed to the person who was accountable for taking these decisions. And he, I'm sure, would say, rightly, that many of those responsibilities were for individual chief executives of individual hospitals, many of which he didn't have statutory authority to direct, and that has been changed since the pandemic as part of the Act as well. So I'm simply being as clear as I can about the way that the system ran. It doesn't mean I didn't feel it. I felt it deeply.
It's not that, but I'm sure he would say there were others under him, cells, no doubt, call them what you will, but doesn't the buck stop with you, Mr. Hancock?
Yeah, that's why I'm answering the questions.
Can I ask you this then, please? Was the need to improve ventilation in hospitals and healthcare settings an area of focus for the Department of Health and Social Care, not just the NHS?
Yes. Also, but all I can do is repeat the situation as it was. I can only explain how the system was run.
A different, perhaps, aspect to IPC measures. Universal mask wearing was brought in on the 5th of June of 2020. Masks for hospital staff, face coverings for visitors and outpatients. Do you think in the event of a future pandemic, universal mask wearing in hospital settings should be brought in earlier?
It should be brought in immediately, and supplies need to be ready, preferably in each hospital, to make that possible.
Finally, in relation to this topic, you've mentioned their supplies. The inquiry has heard a great deal of evidence about FFP3 masks not fitting a diverse range of face types, ethnicities, indeed even not fitting women. When did that particular problem come to your attention?
It came to my attention at some point in the middle of the first wave, I think, or maybe a bit later than that. But I in fact, I attended a fit test with a number of ethnic minority nurses, and saw for myself the difficulties that were caused by by stock being essentially designed around one ethnicity.
No, so you became aware of it. It perhaps matters not precisely when it was in the first wave. I'm going to ask you again, did you do anything about broadening types of... Okay, what did you do about it?
Well, again, my answer is the same. I raised this issue with the NHS.
When you left office, as far as you were concerned, was there a more diverse range of FFP3 masks available?
I think so, but I wouldn't be able to say whether it was fully adequate or not.
Sticking with the issue of inequalities or indeed inequalities, I suspect. You are aware, I think, that certainly older people were more at risk, but there was also a greater risk of severe COVID and indeed mortality for people from a Black, Asian and minority ethnic community. And I think you were aware of that from about April 2020, when you said there was sage advice given to you identifying risk factors, of which gender, ethnicity, obesity and indeed age were mentioned.
Well, there was the scientific...
Can I ask the question?
Sorry, I thought...
It's all right. The question I wanted to ask you was this. You became aware of it and you said you wanted the SAGE documents to be published. Do you know whether, in fact, those SAGE documents were published so that the public could see the people who may be at greater risk?
Yes.
All right. Christopher Whitty has told us that those from Black, Asian and minority ethnic communities, particularly in the first wave, Black ethnicity were at people of higher risk, South Asian ethnicity at greater risk in the second wave. They're more likely to get COVID severely. Infection was more likely to lead to mortality. Were you aware of those findings as a result of the PHE review in June 2020?
I was aware of this long before then. The thing I was going to say when you asked the first part of your previous question was that this wasn't just about the statistical and scientific reports, whether from SAGE or from PHE. The first 4 doctors to die were all from ethnic minority backgrounds, and several had come to the UK in order to work in the NHS. So I felt it very strongly. I saw it. And so, yes, it came through in those official reports, but that PHE report came through long after and this became absolutely crystal clear that this was a major problem.
You say in your statement that your understanding that COVID-19 affected people according to various characteristics, of which ethnicity was one, was at the forefront of your mind throughout.
Yeah.
Right. But I am going to ask you, what did you actually do about that?
Well, the first thing I did was try to stop the spread of the virus.
All right. Was that through IPC measures and the
lockdown?
Like we discussed, and lockdown?
Yeah.
All right. Did you take any specific steps to address or try to address the disproportionate impact in the hospital settings on people of BAME origin?
Before the pandemic, I had given a speech about institutional racism within the NHS. Yeah. It is something that I was already worried about. The ability to tackle something deep-seated like that is very hard. But I'd raised the issue and brought in a series of measures essentially about empowering people to speak up. I mean, before that, in my time in government, I'd been involved in this issue as well. For instance, when I introduced name-blind applications to the civil service. So this is an area that I care about, I knew about, and I was worried about. So I was highly alert to it when the first deaths of doctors were all people from ethnic minority backgrounds. What I could given my responsibilities, as opposed to the NHS's responsibilities, my responsibilities was to make sure that people got, that this was reduced as much as possible. The single biggest thing I could do was make sure that lockdown was strong enough. That was the best way to save lives across the board. There are a combination of sociological and potentially clinical reasons for this. And what the next stage that we took was to try to understand how much of this problem was due to, directly due to, if you like, a different genetic response to COVID according to ethnicity, and how much of it was due to sociological situation. For instance, the fact that more people exposed to the public in hospitals, like hospital porters and nurses, have a much higher proportion of people giving that public service are from ethnic minority backgrounds, and that was the purpose of the PHE report. And then the further work that was done by Minister Badenoch to try to get to the bottom of it. What I'm trying to say is I was absolutely aware of this problem. It's work I'd already done, an area I'd already done work on before the pandemic, and clearly it is it's a significant problem that needs to be addressed.
All right, can I ask you about some two WhatsApps, please, that you were involved in a chain with Helen Whately, who was the Minister for Social Care at the time. And this is in June 2020, so it's around, excuse me, just before, I think, the publication of the PHE review. Helen Whately says, one more thing on the NHS workforce. I think the BAME next steps proposed are important, but don't go far enough. There's systematic racism in some parts of the NHS, as seen in NHSBT.
Yes.
Do you know what NHSBT stood for?
Yes, that's NHS Blood and Transplant.
Right, thank you.
And they had recently, it's all in the public domain, in 2019, they had been involved in a significant, there'd been an uncovering of racism within NHSBT.
All right. She says, now would be a good moment to kick off a proper piece of work to investigate and tackle it. And you say, yes, agree 100%.
Yes.
Were you agreeing there to the systematic racism or the need?
Both.
Thank you. Can you make that happen? And Helen Whately says she'd be delighted to. She's on it. And then can I flash forward a year, please, to the end or nearer the end of this chain? 5th of June 2021, so just before you leave office, you make reference to a E&D glossary published by the NHS. You ask her, what do you think of this? She says it's odd, not something the NHS should be doing, no reason to have an NHS definition of colonialism. She says, I haven't seen it before. I do sense there's a gap between the approach the NHS has been taking on racism and inequality and the stance from Number 10 and Kemi, who I think was the minister working on
Minister
inequalities.
Badnoch, yes.
Yeah. You say, yes, problem is there is a racism problem in the NHS, but I'm pretty sure this hard left stuff is not the way to tackle it.
Yes.
She says, I agree, one to discuss after the recess. Now, Mr. Hancock, I want to be clear about how that racism problem that you are seemingly acknowledging in those messages actually played out in the healthcare system's response to the pandemic. So not the wider issue.
I understand. So as you can see, a year earlier, we were discussing the problem of institutional racism in the NHS. Fast forward, and one of the things the NHS has brought out is an equality and diversity guide, which, if I remember it, had a glossary of terms that effectively followed a hard left critical race theory ideology. My strong view is that racism was a problem and is best tackled by treating each individual as a person and being and treating the colour of their skin the same way as you would consider the colour of someone's eyes. Of course, you need positive support to ensure that past barriers are removed. But the problem is, if you instead start to try to treat people where the community they're from is more important than their individual personal capabilities, hopes and dreams, then you will end up making the problem worse, not better. So that is an explanation of what I mean by that exchange.
All right. What I wanted to know, though, was that there are maybe many wider systemic problems in the NHS, but can you think of a practical way that played out? We've looked at PPE not being sufficiently diverse, but can you give another example of how that racism affected the healthcare system's response?
Who's promoted to what roles?
And how did that affect the response of the health system to COVID?
So there are far fewer people from minority ethnic backgrounds promoted to senior roles within the NHS. And when there is whistleblowing by somebody from an ethnic minority background, they are not taken as seriously in many instances. I could give examples, but
we've heard lots.
The solution to that is positive support from people who are from backgrounds that have been affected, but also ensuring that the system treats everybody as an individual, irrespective of the colour of their skin and the community that they come from. The practical consequence of this is that there were far more people from ethnic minority backgrounds in the junior ranks within the NHS who are more likely to come into contact with patients and therefore more likely to catch COVID. And therefore, there were more hospitalisations and more deaths as a result of this. So that's one example, but it's something that needs to be sorted out, whether there's a pandemic or not.
Can I ask about perhaps an allied topic, and that is vaccination as a condition of deployment, or VCOD, as it's called? I see you raise your eyes there. Just want to spend a moment or two looking at this, and we haven't, so that you know, featured majorly on this in the evidence to date.
Okay.
All right, so just take your time, please, Mr. Hancock. I think the idea that there should be mandatory vaccinations for those working in healthcare and social care settings started to be discussed in Cabinet, I think, in March of 2021. And we know it was brought in social care, and after you left, there were plans to bring it in healthcare, all right? So some of this doesn't necessarily involve you, but go back to the beginning, please. And can I ask, please, that we look on screen at INQ 40920064, which should be a COVID-0 meeting minute from the 17th of March.
2021.
2021, yeah. All right. And it starts with obviously bringing it in social care, but there are issues here which will impinge upon the decision to roll it out for NHS staff, all right? So that's why I'm asking you about it. And you can see there that as you discussed VCOD in health and social care settings, you say this was a moral and practical issue. The moral case was clear. Carers should take all responsible and proportionate steps to keep those they are caring for safe. There are significant practical questions which are important and difficult. DHSC was proposing to bring into the force vaccination of staff at care homes for the over 65 as a first step, all right? For you, what was the moral case for bringing in VCOD?
The moral case is that, is as set out here, if you are employed to care for others, then you should take reasonable steps to ensure you are not harming those in your care. A clinically proven vaccine is a reasonable step that should be expected. I'm not in favour of, we're not talking about vaccinating, requiring vaccinations for everybody. I'm talking about requiring vaccinations for all those who then choose through their employment to put themselves in close proximity with people who may be very vulnerable to disease. This, as you say, this didn't come into force. I think that's a mistake. I did bring it in social care. Yeah. I was persuaded to do social care first and then the NHS later. I regret that. We should have done it all at the same time. It should apply for flu vaccines as well. And it's an irony that the very first meeting we had on coronavirus right at the start of January 2020 was in fact a meeting about bringing in vaccination as a condition of deployment for flu in order to save lives and reduce winter pressures on the NHS. Right.
Putting aside your regret now that you didn't roll it out across both health and social care, we can see further down in the minute that you made the point there that in the NHS this was much less of an issue, with over 90% of those in patient-facing roles having been vaccinated. Figures are lower in London but climbing. Yeah. But they were lower in social care. All right, so that's one side of the argument. The Minister, I think, for Care, if we go over the page, please, addresses some of the potential inequalities issues, which is why I wanted to ask you about it. She made the point it would be important to address the fairness of why this policy was being applied to certain carer groups and not others. Go down again, the policy could create a challenge for the workforce where there's already significant vacancies. And down again, please, to E. Thank you. Black, Asian and minority ethnic communities' hesitancy should not be underestimated. And so to mitigate this, the handling needed to be clear. The legislative proposals would feel authoritarian. It was important to have families and trusted local voices in the sector. So clearly a concern that it might impact on BAME communities. Reflecting on the Minister of Care's observations there, do you agree with her statement that the government needed to involve trusted local voices early on if you're thinking about bringing in mandatory vaccinations of health and social care staff?
Yes.
How might that in fact be rolled out, do you envisage? How do we bring in those voices?
Well, we actually had a lot of experience of doing that in the wider vaccination programme. For instance, one of the things we found was most effective in increasing vaccination rates amongst people from Black, Asian and minority ethnic communities was to ensure that those doing the vaccinating and organising the vaccinating were also from those communities to help people feel safe. The reasons for higher hesitancy amongst communities that feel that don't feel as connected to the authorities is widely reported, and it's important to take it into account. The attitude that we had was that we shouldn't think of the communities who were more hesitant as hard to reach. We should have the humility to accept that it's that the government and the authorities look more distant to some communities, and that's as government, that's our problem, not theirs. And so there's lots of practical steps that you can then take, and all the work that Minister Zahawi led in the vaccine rollout to increase uptake amongst BME communities could equally be applied within health and care settings. Now, as it happened, the concerns over staff leaving didn't materialise. People did take the jab. And it brings me back to this point that we understood that there would be concerns, but that doesn't make it any less a rational policy to require people who are caring for others to protect those others as much as is reasonably possible. And if you look at point A, Helen's point here is, in fact, we should have been doing it for the NHS as well. She was saying that it might look, why is this policy being applied to certain carer groups and not to others? What she means there is, what on earth are we doing only doing this in social care? We need to be doing it in the NHS as well, where the problems, including of nosocomial infection, were, if anything, worse than in social care. So I was pushing for it for flu at the start of the pandemic. I pushed for it for both. I accepted in the sort of practical necessity that happens in government sometimes that it was better to do it in social care than in the NHS. And after I left, they dropped it within the NHS. I think that's a mistake and it should be changed.
All right. And do I take it then that in the event of a future pandemic, once there is a vaccine,
yes,
you would advocate for mandatory vaccinations for health and social care staff?
I would do that, and I would do it right from the start. You know, we made vaccinations available to people working in health and social care as part of the wave one right at the start, and I would make it mandatory as soon as there is enough clinically validated vaccines.
Final topic, please, if I may, before our afternoon break. Can I ask you, please, about the monitoring of deaths of healthcare workers from COVID-19? From your perspective, was any department or organisation actually monitoring the deaths?
Yes.
And who was that, please?
There wasn't right at the start, but I got individual reports, and then I set up a system for monitoring that. I can't remember whether it was NHS England or PHE who put that system in place, but at my instigation, that was done. Yeah.
There is further work, I think, that you asked to be done in relation to investigations into deaths of healthcare workers. And can we have up on screen, please, INQ 474567? In May 2020, you wrote to Jeremy Hunt, who was the chair of the Health and Social Care Select Committee. You'd obviously been before them, and you undertook to confirm to the committee whether it was the HSIB that should be involved in investigation of death. And if we scroll down the screen, you say you've looked into the best approach and you've set in place a process for medical examiners to review the deaths of health and social care workers from COVID.
Right.
Whenever the medical examiner becomes aware of a health and social care worker having died, and there believes there is a reason to suspect that the staff fatality was due to coronavirus, there'll be a process to notify the employer of the deceased member of staff.
Right.
Do you know why there wasn't any investigation process in place prior to you making this clear in the letter to Mr. Hunt?
No.
All right. We know that in due course the Department of Health published some guidance on this process. And to cut a long story short, if I may, Mr. Hancock, by 2022, the National Medical Examiner's report stated that they had looked at, I think, 474 deaths, some which will be social care, some which will be healthcare workers, and concluded that 357 of those cases, the healthcare worker had been exposed to COVID at work. Right. The inquiry has heard evidence that reporting through the HSE under the RIDDOR, or reporting of injuries, diseases and dangerous occurrences regulations, to give it its formal title, that there was underreporting. Now, were you aware of underreporting through the RIDDOR process?
I'm not surprised that if there's been a finding of underreporting.
It's not quite what I asked you. I asked you whether you were aware there had been a finding.
There's a deep statistical answer to that question, which is that none of this reporting was accurate at the start of the pandemic. And underreporting is much more likely than over-reporting in these sort of circumstances. And as a trained statistician, I understand that the statistics you were given are only a guide to the actual underlying truth. And so I suppose I would have taken it as read that there'd be a degree of underreporting, and that needed to be improved over time, hence putting in a system.
Do you think then by the time you left office there was an adequate way of knowing how many people died, and if so, whether they had in fact acquired COVID or the future disease at work?
I'd say we had an improved estimation process, but because of the impossibility of knowing for sure the source of an infection, in fact, the numbers are unknowable, and I would caution against spurious accuracy in this example. So, for instance, the paper that you brought up earlier that had the exact number of deaths from hospital-acquired infection, that's the reported number. It is an estimate because whether somebody acquired an infection in hospital or in the community is not always clear. And I would suggest that 4 degrees of accuracy down to the individual single figure is not appropriate. There needs to be a degree of rounding in those estimates, and an acceptance that sometimes you don't know where an infection has come from.
No, I follow that, but the hospital-acquired, or hospital-onset, hospital-acquired was for those people who tested positive 15 days after their admission to hospital, and PHE were pretty certain that if you were getting tested positive 15 days in, you caught it in the hospital. That's why I focused not on the suspected, not on the probables, but on those where there was pretty good certainty that you got it in the hospital. I don't want anyone to misunderstand you. Are you quibbling with the figures that were provided by PHE about the number of people that caught and indeed died from it?
I'm not. I wouldn't quibble. What I'd say is that in understanding all of these things, you have to understand that there is a degree of uncertainty over all of the figures. We had the same with how do you measure deaths from COVID or deaths with COVID, and at what point is there a cut-off from having had COVID to dying because COVID was underreported on death certificates. So all of these things, all of these statistical techniques are the best way, and we improved them over time, but they're effectively the best way of trying to measure something, and rather than an absolute concrete figure.
Would that be a convenient moment?
Certainly. I shall return at 3:05.
All right.
Scary.
Thank you, my lady. Mr. Hancock, can we discuss briefly the shielding programme?
Yeah.
And just so that you know, we've heard from Professor Whitty and a number of others about how it was set up, who made the list, who didn't make this. I don't want to ask you about that,
Yeah.
all right? But I think one of the points you make in your statement is that there were difficulties, certainly at the beginning, linking data between various either government departments or computer systems to enable you to contact the individuals that were going onto the shielding list. Right? And you say in your statement that you were ultimately required to issue 4 notices under the Control of Patient Information Regulations to help the NHS share the relevant data. Is that right?
Yes.
All right. And in the run-up to the issuing of those notices, could we have a look on screen, please, at INQ 478857? 13th of March 2020, so just before we go into lockdown, the Secretary of State is happy with the approaches. He's happy for NHS Direct.
No, happy to direct.
Sorry, you're quite right. Happy to direct NHS Direct to collect, analyse and disseminate data to DHSE and NHSX through
Section 254.
Yeah, and the notice under the Control of Patient Information. He agrees not to explore regulations at this stage under GDPR. He agrees to extend the data opt-out for 6 months. He's asked for more advice about if he can delay indefinitely. I just want your help with that final bullet.
Yeah.
What were you trying to achieve, if I can put it like that?
Okay, so the 4 copy notices, of which one was very significantly the most important, were put in place to allow the NHS to use data more effectively, and to share data through any secure platform, whereas previously the rules had the effect of requiring data shared across the NHS to be done so on NHS systems. So NHS had its own email system, for instance, whereas there's perfectly adequate ones that are much better and much more secure that could be brought in from outside. So the effect of the copy notice, what we did was we wrote it on, it ended up on 2 sides of A4 to get down to the front line to say you can share data properly, effectively, so long as it's on a secure system, but it doesn't have to be according to the unbelievably complicated rules that had grown up in the past.
Okay, so this was to help the shielding letters go out?
Yes. So with the shielding letters, that was specifically about allowing the data to be shared between DWP and the NHS. And NHSD here is NHS Digital, who had the statutory responsibility for protection of data in the NHS.
But the referencing to opting out and asking to delay indefinitely, was that what were you trying to achieve there?
Oh, I wanted this new system, which was going to be much more effective and turned out to be much more effective, to be permanent.
Right.
And it is it's a mistake that it was rolled back. And actually, there is legislation in front of Parliament now to allow us to get back to where we were in the pandemic, when the effective use of data in a modern way was the best it's ever been in the NHS, and then unfortunately has sort of encroached backwards again.
Right. Do you think the inability to share data easily without a copy notice hampered the ability of the healthcare system to respond?
Well, we put it in place pretty early. Yeah. So Matthew Gould, the head of NHSX, and Simon Madden, who wrote this note, did incredible work early on to spot that this was going to be a problem and then to get across it. There were some instances, like putting together the shielding list, where it was a practical problem. And so there were concrete use cases for it, but they had spotted early enough that this was absolutely necessary. And it went on to, for instance, underpin the effectiveness of the vaccine programme.
A number of witnesses have spoken about either paucity or total absence of data in various respects, often in relation to ethnicity collection and the like, and have urged upon her ladyship to consider making data recommendations.
Yes.
Do you have any data recommendation to make?
Oh.
What is it, please?
Yes, please. I'm going to answer off the top of my head, but I'd be very happy to write afterwards, because it's a subject I feel very strongly about. Because I think that the NHS can only operate effectively if it has much more modern and effective data sharing systems.
Can I ask you to focus your answer on the pandemic response?
Yes. I'll give you 2 concrete examples. One is the collection of data for management purposes, which we've discussed in relation to understanding how many beds the NHS effectively has. That system has improved a huge amount, and last year the NHS let a contract to allow for that to be done much more widely across the NHS. So in a way, there it's keep pushing and modern and using modern data better, using data keep using data better in a modern way. But the area that's most important is the ability for anybody who needs it, who has the consent to see it, can see somebody's individual data to be able to treat them and see all the other treatments that they've had. That includes ethnicity data, but also all of the data that's pertinent to that treatment. And that is needed in normal times, but by God, it's critical in a pandemic. The third area is data. I said two, I know, but the third is also important, which is use of data properly for the organisation of provision of services. So, for instance, telling people when they can come, the whole 111 First system that we talked about, being able to turn that initial phone call into an appointment and make sure that the medical records and the doctor or nurse or appropriate clinician is there and a room booked or a place booked for that to happen. That is essentially a data issue, and unless you essentially completely free up the use of data within the NHS, we are never going to solve that problem.
Can I come back to shielding?
Yes.
Please. We know that DHSC was one of a number of departments that fed into the shielding programme as it was rolled out. But from the department's perspective and your perspective as Minister, did you make any steps to try and ascertain whether the shielding programme worked in the sense that it prevented the most vulnerable people from becoming infected?
Yes, there was work done to assess the impact of the shielding programme. There is another difficulty of measurability here. Because there was not a control group, as in everybody who we thought needed shielding, we put into the shielding programme. We didn't hold a group back and say we won't do it, we won't apply the same support to them because then we can measure that, as you would in, for instance, a clinical trial. That means that it is harder to measure. That emphatically does not mean that it wasn't a success. And I've seen some paperwork put before the inquiry which implies that the shielding programme wasn't effective. That is completely untrue. There is no reasonable assessment of the shielding programme that can find that if you give people support and ask them to protect themselves from interactions with others, then they are then they're anything but less likely to die of COVID. And of course, there were a higher proportion of deaths amongst the shielded population than there were amongst the population at large. And that's because they were vulnerable. That's who was brought into the shielding programme.
All right. You made reference there to the inquiry seeing some paperwork that implied the shielding programme wasn't effective. That's not quite an accurate representation of what Professor Snooks told us. But can I ask you, do you think that the high level of hospital transmission or hospital-acquired COVID undermined the efficacy of shielding? Because if you put a vulnerable person into hospital where they're more likely to catch it, you are thereby infecting the very person you wanted to protect. That's what she was driving at. So untrue might be perhaps an unfair
Well, she said because you can't conclude this, therefore it didn't save lives, and that was my reading of it, and right. And is not accurate. If that wasn't the intended interpretation, then that's good. The answer to your question is no, because without shielding, unfortunately, because of the extent of nosocomial infection, people going into hospital would be even more badly affected, because you'd still have the hospital-acquired infections, but you'd have more community-acquired infections. And also, shielding did mean that GPs knew which of their patients were regarded by the data to be most likely to be vulnerable, and therefore who they needed to give extra support to and protect from potential risk of infection. So no, I don't think that hospital-acquired infections, they were obviously a bad thing, but they didn't undermine shielding at all.
All right, and finally on shielding, were you involved in any discussions about specific measures that might address the heightened risk for the clinically vulnerable who had to attend healthcare appointments?
The which risk? The hospital risk?
Yeah. The heightened, I said,
Heightened risk.
Heightened risk. Let me ask you again. Were you involved in any discussions about the specific measures that might address the heightened risk that clinically vulnerable people faced when going to healthcare appointments?
Not that I can recall.
You mentioned GPs and shielding. Clearly, the rollout of the shielding programme added a burden to them in that regard because they had to monitor the list. Can I ask you about a different aspect of GP response? And I think the BMA wrote to you on the 18th of May. Can we have a look at INQ 97897, please? We're in May 21 here, Mr. Hancock.
Yeah.
And the BMA wrote to you expressing widespread anger, frustration, and disappointment of the GP workforce and requesting a meeting with you.
Yeah.
And if you scroll down the screen, please, can you see the paragraph beginning, despite the incredible work done by GPs?
Yeah.
Their teams over the last year to care for our patients, they do not feel supported. This feeling is further exacerbated by sections of the media reporting that practices are to blame for not seeing all patients in face-to-face consultations. Practices have been open to their patients throughout the pandemic, and at least half of all appointments have been delivered in person. This is something that should be celebrated, but instead the profession feels let down and demoralised at the suggestion that they are failing their patients.
Yes.
Had you or the department been involved in blaming in any way GPs for what is perceived to be a lack of face-to-face consultations?
No, on the contrary, I was and am a strong supporter of virtual consultations. There were discussions in the media about the requirement to have more face-to-face GP appointments. I didn't subscribe to that view whatsoever, and in fact went out of my way to make the case for online consultations, and still do. It doesn't matter. Well, I mean, it's more important in a pandemic, but it should still be a core part of the service that GPs provide online and telephone services. So I agreed with this. I agreed with the thrust of what Richard Vaudreuil was saying here, but obviously I didn't agree at all with the political spin that he puts on it.
All right.
And actually that didn't accord with my widespread discussions with GPs on the ground, for instance, the Royal College and or GPs in my constituency, or so. But you know, the BMA GP committee is a particular beast.
Right. Do you think, though, that in the strong support given by you and others to virtual consultations, that led to a perception that face-to-face appointments had been stopped?
No, I don't think that's fair at all. There were some media reports saying we want more face-to-face consultations, and I was saying no, we want more. There were too many face-to-face consultations, so I wasn't saying that at all. No.
Right. So you weren't, although you were encouraging virtual appointments, you were not saying. You were not trying to discourage face-to-face or say that there weren't any face-to-face, if I understood you correctly.
That's right, and the worry expressed, which I understand in this paragraph, was a worry about as he puts it, sections of the media who were making this argument, and I thought that the argument that GP appointments ought to be face-to-face, and there's a sort of values-based argument there. I thought that was a load of rubbish.
All right. I understand that you disagree with the sentiment, but people's perception might be a different matter. Did you hear reports of people perceiving that GPs were not open for face-to-face consultations?
Yes, of course, yeah.
And what do you think caused that perception, given that you acknowledge that you heard about it?
There was a presumption. There was a push to have more virtual consultations, and that was the right thing. So there was some, push back against a change in the right direction. But this happens often when you're trying to change something. Right. The point about this letter is I was essentially in agreement with where Richard was coming from.
All right. In the rollout or increased use of virtual consultations, can you help with what consideration was given to those that may not be able to access either a telephone or let me finish, please. Particularly, perhaps those who are unfamiliar with virtual appointments, those for whom English is not their first language, those that have poor internet connectivity and the like. What did you do to try and address those particular impacts?
Well, the first thing I did was increase the use of non-face-to-face and virtual appointments, because increasing virtual appointments frees up space for people who want face-to-face appointments. So the argument that you put, I understand, has been levelled at me many times in my enthusiasm for supporting people in the NHS where they are and what's convenient to them, which often means virtual appointments, but it doesn't always mean virtual appointments. There are always going to be some people who need to have a face-to-face appointment, either because of the nature of their medical problem, or because they may never use a computer. The point is that if you have a more efficient system using modern technology, you free up space for more of that rather than less. I'm totally against an online-only system, whilst being very enthusiastic about the availability of online.
Sticking with primary care, can I ask you about pharmacies, please? We have heard evidence that the national PPE supply was not accessible to community pharmacists. They couldn't get FFP3 masks. They couldn't access the PPE portal until August 2020. Do you know why there was a delay in allowing community pharmacists access to that PPE portal?
It's a very good question. And as you'll know from the paperwork, I pushed for them to have that access, and eventually that happened. In a world of highly constrained PPE availability, we had to be careful to ensure it got to where it was most needed, and there's a hierarchy of that. But I wanted it to be available to pharmacists. Also, you've got to remember that pharmacists are private businesses, and outside of the pandemic, of course, they buy their own protective equipment in the same way that most social care providers are private businesses, and before the pandemic, they buy their own equipment. So the government was not the only provider of PPE in this situation. Obviously, for the state-owned hospital system, the core NHS, we were, although hospitals buying their own PPE without the NHS England or the central government having anything to do with it is a good thing, not a bad thing in these circumstances. So there's a balance to be struck between about who the state provides for, and also how, given we as the state had limited access, how that is then distributed.
So is the answer that in times of constrained supply, community pharmacists, rightly or wrongly, were deemed to be lower in the priority for people that needed access to the PPE portal?
That is accurate, yes.
And another aspect of pharmacy that I'd like to ask you about is the life assurance scheme. Now, Mr. Hancock, you wanted from the very early on all staff to be included in the life assurance scheme.
Yeah.
And you made that clear in an email, I don't need to call it up, back on the 11th of April.
Right.
The scheme is then rolled out on the 27th of April, and pharmacies in a hospital or GP setting were included.
Yeah.
But those in community pharmacy certainly felt that they were excluded, and Sir Christopher Wormald didn't disagree about that. If you, back on the 11th, said all pharmacy staff to be included, can you help with why, when the scheme was announced, they weren't, or it wasn't made explicitly clear that they weren't included?
Didn't we clear that up shortly afterwards?
You did, but that's not what I'm asking. We'll come to the clear up in a moment.
If you want, I'm going to give you the brutally honest answer to this with some trepidation because of our earlier discussion about accountabilities, Chair. The pharmacy contract is managed by NHS England. In order to maximise taxpayer value for money, NHS England is, by tradition, really very tight on pharmacists. I am a big supporter of community pharmacy, and there is therefore inbuilt into NHS England senior management a lack of enthusiasm for giving more to community pharmacists than they absolutely have to. And that's born of the fact that their main relationship is a contractual negotiation. And that, I think, is probably the reason that they did it this way. But I've tried to describe that in a way that is an explanation rather than trying to, you know.
Can I just ask you about that? I asked Sir Chris Wormold, and he said that the reason they weren't initially included was because it wasn't agreed by the Treasury, nothing to do with NHS England. Were you aware that the decision that all pharmacies ended up only being pharmacists in GPs and hospitals was a Treasury-related decision? It sounded like you're saying
I wasn't aware of it. But in the dynamic of how hard we pushed, that will have been the end. That will have been the last thing on the list, I would have thought, from an NHS England point of view.
All right, so there's a disconnect, if I can put it like that, between what he told us and what you told us. But what I want to ask you about is the effect on the pharmacists.
Yeah.
Because clearly, you're right, within 3 days you'd made it clear it was to apply to all of them. But we've heard evidence from particularly the National Pharmacy Association that even that 3-day wait for them was demoralising, demotivating.
Yeah.
And they think that effectively community pharmacists are being treated as an afterthought.
Yeah. So that my impression of the system, and if there's a Treasury element to this as well, then you'll see that in the paperwork. I wasn't aware of that, or at least I don't recollect it. But you're absolutely right. My sense was also that the system was not looking after community pharmacists enough. That was my feeling too, and hence I changed it as soon as I could. But it was that is a classic of how decisions get put together in those situations. You become Secretary of State and you think, my God, I'm responsible for a £150 billion budget. And then you find there's all sorts of constraints on what you can do because others have different views and attitudes. And this is an example of that.
If your impression of the system was that pharmacies were something of an afterthought, and yet you're encouraging people to go to your pharmacies to pick up medication for those that are clinically vulnerable and shielding, go there rather than going to a GP for medication, why weren't pharmacists higher up in your mind and the mind of the department?
No, they completely misunderstood my last answer. They were absolutely top of my mind, but I couldn't necessarily drive that through the system.
Well, if it's a misunderstanding, then it's mine. Is your evidence, Mr. Hancock, that they weren't an afterthought as far as you were concerned?
Not as far as I was concerned, but they evidently were as far as the system was concerned because of how that announcement came out. If you take it through the evidence that we've been looking at in the last couple of minutes, I said it should be all pharmacies.
You did. Yeah.
The report, the answer came. The formal documentation came out saying it was only the NHS pharmacies. Once I found that out, I would have probably expressed my frustration in Anglo-Saxon terms and said I'm going to sort this out. And so I got on the next time I was in front of in public, I made clear that this was going to everybody, and I would have had to fix it. That sort of problem is meat and drink in Whitehall. It happens all the time. It's just part of the daily life of an active minister. That you have to go and fix problems all the time, and then take accountability for the system as a whole.
Can I move on to long COVID, please? We have heard evidence that it was known at the start of the pandemic it was likely there would be long-term effects caused by the virus, even if we didn't know precisely what they were, how severe they would be, and how many people might contract long COVID. Were you made aware that there would be some long-term effects, even if the precise nature of the effects were not known at that stage?
Yes, I recall discussing this with Chris Whitty in January 2020.
Right. Okay. And given that it was known that there would be some, what, if anything, did you decide to do to try and work out what they were, how they could be managed, how they could be treated?
Yeah. So obviously, before there were any COVID cases, there was nothing that you could do about this. The only thing you could do is try to reduce the number of COVID cases, i.e. bringing in a lockdown. By around May, June 2020, I was aware of this being a problem, not least because it affected people close to my heart. My mother still suffers from long COVID from that first wave. So this is close to my heart. So in around June, I convened experts and the NHS and others to try to understand what we knew by then. This, of course, June is only 2 months after the peak of the first wave. So people's slow recovery was only just becoming evident. And then we established a long COVID clinic.
All right, I'm going to come on to those.
Yeah.
Just to help you, in fact, it was in May 2020 that you asked Sir Simon Stevens to develop plans for provision of those suffering with long COVID.
Right.
When you said you wanted him to develop plans for providing for those suffering, what were you talking about? Financial provision, medical provision, pastoral support?
Yes, primarily medical provision, but across the board. So if that was in May 2020, this is less than 4 weeks after the peak. So people couldn't have presented with long COVID longer than 4 weeks after infection. And so that will have been in anticipation of there being long COVID as a concept, if you like. And it was definitely before there was a name long COVID that I was pushing to ensure we were ready to support those who got it.
We know you set up the round tables. I don't need to ask you about that. That detail is set out in your statement, Mr. Hancock. But you did identify that further research may be needed. And in particular, you asked for further research on those that were not hospitalised but still got long COVID. Why did you ask for research to be done to that cohort of sufferers?
Because the evidence was that the severity of your first bout of COVID was not correlated with your likelihood of long-term symptoms, my mother included. She was not hospitalised, and we're 4 years later and still suffers the effects. So the early research showed that there didn't appear to be such a correlation between severity and longevity of the COVID problems. And so just analysing the impact of long COVID from people who are hospitalised missed a whole load of the patients.
Now, you mentioned long COVID clinics, and when they were announced or launched, there was initially, I think, 40 clinics in November 2020, and by June, the 11th of June, so just before you left office, now 80 clinics. All right, we're up and running. But why were long COVID clinics decided to be the best option for England? Can you help with that?
The reason is that long COVID presents in a very wide array of ways, and the part of the problem with the research is that was, unlike COVID itself, there was not a clear and simple presentation. My best understanding of it is that long COVID is often where the neurological elements of the COVID viral impact are long-standing, are a bigger thing than the immediate impact, which was essentially respiratory. And neurological conditions are, by their nature, much more difficult to research. And so it was needed to have a cohort to study to see these broad presentations of long COVID. And there's another aspect as well, which is that I thought if I just said to the NHS, just make sure you look out for long COVID, it would have just gone into the ether and nothing would have happened. Whereas if you have specific long COVID budgets with specific dedicated clinical and other staff and a specific budget, including a research budget, then you will actually get some action that you can that's tractable that you can follow.
So were you actually involved then in saying you wanted X million or whatever it was spent on long COVID research and X million on long COVID clinics?
So it will have come from within the NHS budget. So it will have been, Simon will have found the budget for it, I think. And so his decision over exactly how much to put into it, what I was doing was driving action on the NHS side of the fence. It comes back to the discussion we've had a number of times and what you do as Secretary of State if something's an NHS responsibility. The answer is, in this case, I convened a round table, I pushed it to Simon Stevens, but he took the action.
Right. So in this example, you asked for there to be greater funding for research and clinics, and you said to him, over to him, and you did it. Did you monitor to ensure that he had put into place that which you had envisaged?
Yes, there were a series of meetings, and in fact, I visited some of the long COVID clinics.
Right. Whilst you were Secretary of State, were you aware if there was any monitoring of the number of healthcare workers who contracted long COVID?
I think there was, but I haven't got the evidence in front of me.
No, we're not sure that there was actually that data, in fact,
If there
collected.
wasn't, there should have been.
Well, that's what I was going to ask.
Yeah.
Yeah. Why do you say there should have been that data collected?
Well, because you want to know what the impact is on the NHS workforce.
By the time you left office, do you know whether that data
Don't
is
know.
being collected? Would you suggest that should be a matter for NHS England or should be collected?
Yes, it's their workforce. Yeah.
All right. And does it follow from what you said then that whilst you were Secretary of State, you weren't able to assess the extent of absence in the health and social care system that was caused by long COVID?
No, that would have been a matter for the Chief People Officer of the NHS, Priyana Issing, who was absolutely brilliant. And I do recall talking to her about this subject. The other thing to say in this space is not only did I follow up with the NHS, but I was also received submissions from the various long COVID support groups who felt that not enough was being done. So I knew that there was a sense that not enough was being done, and I was pushing the NHS to do more, and they did do more, and opened more clinics and did the research.
Finally, this please, recommendations. If you had to give a recommendation to her ladyship as to how to improve the healthcare system that is not related to lockdown, Mr. Hancock, what would your recommendation be?
Well, I think that in normal times, having the NHS run at less than 100% capacity will increase the resilience of the in the NHS.
Can I pause you there? That's a political decision as to how to fund the NHS and how they choose to run at capacity, and it might be out with her ladyship's remit to say you should have 10,000 more beds or whatever it be.
Most of these decisions are essentially political decisions.
Yeah.
Deciding to lock down is a political decision in the finest sense that politics is how we make decisions in this country at the highest level. The inquiry is surely able to make any recommendations it should choose. The second thing is about use of data.
Yeah.
My view is that the NHS will only survive if it gets better at the use of data, and in a pandemic that's even more important for the three areas that I suggested, and indeed research a fourth. I would hope there'd be recommendations on that, because we do have this example of the COPI notices, and within the NHS the vaccine rollout as well, as high quality data improvements that have not been repeated since. So we should learn from them. And then I suppose the third is the ability to surge. You know, we put together an ability to surge in real time, but a more considered, structured plan to be able to surge NHS capacity would be valuable. You know, if there were, God forbid, a pandemic to hit tomorrow, of course, we'd be able to do it better because the people involved would be able to use the learnings from last time. But if we can find ways to make that more thought through and programmatic, if you like, then that would be a good thing.
Mr. Hancock, thank you. That's all the questions I asked. My lady, there may be some time for some...
Thank you, certainly. And I gather, Mr. Thomas, you'd quite like to get some questions in this afternoon. And you're not attending remotely unless you're a hologram, are you?
Good afternoon, Mr. Hancock. Just to remind you, we've met before. I represent FEMHO, the Federation of Ethnic Minority Healthcare Organisations. Milady, just so that you can follow my questioning, I'm actually going to start with my sixth question because that piggybacks on some of the questions and then I'll revert back to the order. Can I just correct you, Mr. Hancock, on something you said earlier? I think it's my duty to do so. You said in your evidence that the first 4 doctors who died were doctors of colour. It was 10. It was the first 10 doctors. And it's important that I correct you on that. You accept that?
I accept. I'm sure that you have the evidence for that. The first 4. My point, I suppose, is an even stronger one, which is that when I saw that the first 4 were, I knew that we had a major problem.
Yeah, and then 6 follows. The next 6 were black and brown. Okay. When we met during Module 2, we were in fact in agreement about, to use your words, the long-standing issue of racism within the NHS, which you told us was an issue that you were heavily involved in and one that you'd been concerned about well before the pandemic, and you'd just been speaking to Miss Carey about the speech that you gave and so on. Can I ask you this? In the light of the evidence to this module from impact witnesses and experts, and of your own concern about racism within the NHS prior to the pandemic, I'm sure we can agree on this, that structural racism is likely to have been a contributing factor to the disproportionate impact on ethnic minority healthcare workers and patients. Can we agree on that?
Yes, we can, yes.
Okay. Mr. Hancock, if that is right, though, then the assertion you made earlier to Miss Carey, and I'm summarising here, so forgive me because it's a summary of what you were saying, effectively that by working and trying to lock down to prevent the spread, so, not specifically targeting but going for the whole, treating everyone as one mass unit, irrespective of race, that fails to address, does it not, the systemic nature of the problem? Because systemic racism operates through institutional structures, policies and practices that perpetrate unequal outcomes for minority groups. Would you not agree with that?
I would agree with the thrust of it, but I'd say that the solution to that is to treat everybody as an individual. The solution to that is not to segregate society into communities, but it is to address precisely those the barriers that you talk about.
But Mr. Hancock, just if I may, just push back slightly on what you've said respectfully. You see, addressing these disparities requires a tailored, equity-focused measures, not a colour-blind approach that ignores underlying structural barriers. Take for example, the example that you gave earlier, which, with respect, oversimplifies the problem. You will agree with this, surely, that eye colour has no historical, social or systemic impact on a person's opportunities.
Yes.
You'd agree with that?
Yes.
But race and colour does. Race and colour is well documented to influence people's experience and life and lived experience. So you can't compare the two.
No, absolutely not. But I do want to live in a world where I could, and that's the point. And in fact, in the earlier part of your statement just then, you said you can't be colourblind, not taking into account the barriers that people face. in fact, my answer was, we need to remove those barriers. So I feel very strongly about this, in agreement to the with the essence of what you're saying.
All right. I'm coming back onto the questions, and let me see if I can get through these questions as quickly as I can. I want to turn to the question of staff ratios and risk assessments. You approved the dilution of critical care staff ratios to manage COVID-19 patients. Question. Were you aware of or seek reassurance from Simon Stevens on whether specific risk assessments were to be conducted to evaluate the impact of this decision on the safety and well-being of healthcare workers from Black, Asian and minority ethnic communities who were overrepresented proportionately in frontline workers?
Well, I think it would have been impossible accurately to make that sort of assessment for two reasons. The first is, at that stage in the pandemic, we didn't know what the impact was going to be because it was a completely novel virus. And the second reason is that we had to make these decisions incredibly quickly, and to hold up a decision whilst doing a full risk assessment would have led to, in my assessment, much worse outcomes overall.
Mr. Hancock, in hindsight, would you recommend additional safeguards or measures to ensure that such decisions did not disproportionately impact Black, Asian, minority ethnic healthcare workers in the future?
I would recommend that the disproportionate impact is taken into account in making those sorts of decisions according to what is likely to save most lives.
All right. Would you agree with this, that periodic targeted reviews of frontline staff feedback would have been an additional safeguard and something to consider going forward?
Yes, and I tried to put that in place before the pandemic. In fact, it was one of the things that I was working on after the speech that I mentioned in 2019. I think that's very important. I mean, after all, breaking down the barriers that you talk about is not a glib thing. There's a whole series of policy that needs to be put in place to make that happen.
Okay. Before deciding to stretch staff ratios in critical care settings, did you consult with the Chief Nursing Officer or any other senior medical advisors or NHS England about the impact and potential strain on NHS workers, what that strain would be?
Absolutely, yes. It was front of mind.
I want to turn now to PPE. In your witness statement, you acknowledge challenges in the supply of PPE. Chris Wormwald gave evidence to this inquiry in Module 1, admitting that the department had stocked PPE that would be suitable for ethnic minority healthcare workers in smaller quantities. Were you aware of this?
I became aware of it. I wasn't aware of it at the start.
When did it come to your attention, and what, if any, action did you take?
I'm not exactly sure. It will have been sometime in the first half of 2020, and the action that I took was to require that the PPE we were buying was the right PPE for the workforce that we had in the NHS, which is disproportionately from an ethnic minority background.
Were you aware that healthcare workers from Black, Asian and minority ethnic backgrounds faced additional challenges sourcing and being provided with adequate and appropriate PPE?
Yes, and in fact, I went to a fit test where the nurse doing the fit test was from was Black, and I could physically see for myself the challenges of mask fitting as she was doing a fit test for me.
Tell me this, when did you become aware of this? When did it become apparent?
Again, in the first half of 2020, I can't remember an exact date.
What steps did you take to ensure that healthcare workers, particularly those from minority backgrounds, received adequate and high-quality PPE in a timely manner?
Well, I gave the instruction to start buying PPE in January 2020. So it was something that I was aware of and acting on from well before the pandemic hit the UK.
So what happened then? Why didn't it? Why were there still problems in the pipeline?
Well, how long have you got? I mean, there's the problems of the fact that we had a stockpile that couldn't easily be picked, the fact that the demand for PPE shot up, both in the UK when we brought in the IPC measures, but then also globally because this was a global pandemic. Buying PPE became more difficult. Even if we'd had a stockpile twice the size, that still would have been less than 10% of what we needed over the entire pandemic. So there's a whole there's a huge amount of detail on what I did to procure the PPE, as much PPE as we could get our hands on. And the department's criticised for buying too much PPE, for buying too little PPE, to buying too much PPE too expensively. What we were trying to do was save as many lives as possible.
Well, I think, in fairness, it was also criticised for buying the wrong PPE.
Yeah, absolutely, and the stockpiling having the wrong PPE in it. So, all these things.
Let me move on. To what extent was PPE availability monitored, with specific attention to Black, Asian and minority ethnic healthcare workers?
Well, I'm not sure it was monitored enough at the start, and that monitoring got better over time. And one of the key lessons is we need to make sure that the PPE that is stockpiled and then bought in any future pandemic fits the workforce that we have.
I think we can agree on the next question, but let me put it to you in any event. We can agree that Black, Asian and minority ethnic healthcare workers were more likely to be on the front line in patient-facing roles and were disproportionately affected by a lack of suitable PPE. Can we agree on that?
We can certainly agree on the first half of it. And there's excellent evidence from, for instance, Ben Goldacre, who did very good statistical work on this. But I also saw it for myself. I was a big champion of the workforce of the NHS, and in particular those from ethnic minority backgrounds, and also those from whatever ethnic background who'd come to the UK in order to serve in the NHS. Yes.
Would you also agree that there was a lack of adequate consideration for variation of facial features between ethnicities?
Yes.
And this standardised PPE was not providing. I think you've already touched on this.
Yes. I strongly agree with you.
To whom and/or to which bodies would you attribute the responsibility for the lack of suitable PPE available for minority workers?
Well, the stockpile was managed by PHE, but they reported it into the department.
Okay. Let me come to my final question. And I want to be forward-facing and look to lessons for the future. In the light of your first-hand experience and engagement with healthcare workers during the pandemic, what do you think can and should be done to reduce inequalities for Black, Asian, minority ethnic healthcare workers in the event of a future pandemic?
There's so many things that need to be done. I think that the HR systems of the NHS need to be colourblind. For instance, making sure that when people go for promotion, that is done on entirely on merit. I think there are practical things that can be done, like the PPE that we've talked about, but including extra support, mentoring for members of the team from ethnic minority background. But bigger than all of those things is a culture and a culture change. Because people love the NHS, and I love the NHS, we are cautious about criticising it. But this is an issue that needs to be resolved within the NHS, because the NHS couldn't exist without its ethnic minority workforce, and doesn't do enough to support them.
Yeah, can I just touch on one thing you said there, and I'm going to come back to the colourblind. Same point. You can't have a colourblind system where you've got structural barriers.
Yes, you've got to, but the answer to that is to break down the barriers. That
comes first. That has to come first before you can have a colourblind system.
Exactly.
Milady, I think I'm within time.
Thank you very much. Thank you, Mr. Thomas. Mr. Jory, do you want to get your questions in tonight?
Mr. Hancock. I ask questions on behalf of the Independent Ambulance Association. It appears that neither the independent ambulance sector nor the College of Paramedics were consulted regarding COVID measures prior to their imposition in early 2020. The College of Paramedics sought guidance in a letter they wrote directly to you on the 20th of March 2020. I've got the reference for that, but we don't need to perhaps look at it. There was no specific response from you or your department, but can I make clear, she and we attach no criticism given the circumstances at the time. But when the college did receive guidance from Public Health England, this did not seem to take into account the unique challenges of working in an ambulance. Now, I summarise, but I hope fairly, what appears to be your general view expressed here to counsel to the inquiry, Miss Carey, this morning, that guidance was often created by politicians and administrators, when perhaps there should have been more thought given to practitioners and clinicians. So my question is this: in seeking to formulate practical measures and guidance for any future pandemic, and insofar as it affects the ambulance service, would you agree that it is essential that the ambulance sector, i.e. those actually working at the coalface, and including the independent ambulance workers and paramedics who contributed so much in supporting the NHS during the pandemic, that they be consulted in formulating such measures and guidance?
Well, yes, of course the sector should be consulted. I would challenge, even though I have my criticisms of how some things worked within the health system, I would challenge the question that practitioners were not involved in the design of much of the guidance. I'm not sure that's right. I can't answer for whether any one individual organisation was consulted for guidance that I wasn't involved in, but generally there's a vital need to consult people on the ground, both through organisations and directly. But in the case of a pandemic, often you have to bring things in much quicker than you would normally. So instead of a typical 3-month consultation period, you might convene an immediate roundtable on virtually, and then try to make a decision based on immediate feedback. So of course there have to be accelerations of normal procedures. And I'm very sorry I didn't reply to the letter, but 20th of March 2020 was in the middle of when we were bringing in lockdown, and so I would have been exceptionally busy.
As we said, there was no criticism attached to that, but thank you very much.
Thank you.
Lady, thank you.
Thank you, Mr. Joy. Very grateful. I think we'll just see if we can slip in Miss Morris. I don't know.
I ask questions on behalf of the Royal College of Nursing. A question about data. The rates of infection, self-isolation and death amongst health and care staff would have been key indicators of the effectiveness of the government's approach to those workers and their working conditions. And therefore, systematic collection of data on those matters was required. You're nodding, agreeing with me.
Yes.
So what did you do to ensure that the government had data as to the impact of the pandemic on health and social care workers?
So I required the collection of that data, and I publicised it. It wasn't there at the start, and I made that happen. I totally agree with your question.
When did you make sure it was collected?
It was April 2020 when the number of when the first significant number of deaths was starting to happen.
And as to infection rates?
And infection rates, of course, depended on the availability of tests. And so in the early days before I expanded the testing capacity very significantly, it was measurement of infection rates amongst hospital staff was much harder. But as soon as we had the tests to do it, which was probably May 2020, we got on and did that. But as I said, it was actually very hard to drive the increase in testing across the NHS.
And something that didn't require testing, measurement of self-isolation rates. When did you introduce that collection of data?
I don't recall the exact an exact date, but obviously that's also very important.
Thank you, Ms. Morris. Unless there's anybody who's desperate to get away, I think Mr. Hancock's had quite a long day. Just check there's nobody who's got just about 3 or 5 minutes that they want to get in tonight.
I'm here as long as you like, Chair.
I know it's been a long day for you, Mr. Hancock. I'm afraid we have to come back tomorrow. There's no way we can complete. Too many people wish to ask you questions.
Okay.
And so we have an hour and a half, couple of hours left, I'm afraid. So 10 o'clock tomorrow, please.
All right.